Let's talk about some of the cases that I saw in my clinical rotation at urgent care last week. So let's talk about the pink eye. So that patient came in with like pink, red, itchy eye and excessive tearing and yellow crusting for like 3 days. Before diagnosing any conjunctivitis, I always make sure to ask about the contact lens use, any vision changes, any double vision, light sensitivity, eye injury, and any symptoms that could suggest any orbital or preseptal cellulitis, right? But I did my assessment. Her vision was like normal. She didn't have any red flags. She had like good extraocular vision, no double vision, nothing like that. And so my treatment was warm compress and erythromycin ointment and written precaution, like if anything, like her pain gets worse, if she has swallowing, if her vision is compromised, then I ask her to come back to the clinic for further evaluation. And with the conjunctivitis, always make sure that you ask about the contact lens use and how they're using it. They're like taking it off at night or not. Yep. And next case was there for dizziness, and he was present after a fall. So one thing that I learned, like always ask whether the patient is taking blood thinner or not. If patient are 60 or above and they're taking blood thinner, even though they didn't like hit their head or lost their consciousness, you still have to send them to the ED for CT scan. Okay, that's like, yeah, when symptoms seems like initially seems very mild and the patient seems like okay with it and all that, but you still have to send them to the emergency department. So the patient was like about 70-year-old and he was taking anticoagulant. So yeah, we just sent him to the emergency department. So another patient, he came in saying like every time he turned his head, the room like starts spinning. And that description is very important because dizziness can mean like thousands of things, right? Some things like, okay, they're dizzy if they feel like they're gonna pass out. Some may feel like they're off the balance. That's the dizziness. But when they say like true spinning, that makes me think of like vertigo. So for this patient, the dizziness was sudden and it was brief, like for 15 seconds. And it was triggered by head movement, like turning the head up, down, bending down. So that pattern is more consistent with like BPPV, which is vertigo, which stands for like benign proximal positional vertigo. Sorry, I'm kind of mixing it with BPH, but BPPV happens when tiny calcium crystal in the inner ear, it moves the wrong canal. So when the head changes the position, those crystals shift and confuse, and patients feel like, okay, the room is spinning. So, but before assuming BPPV, we always have to check some red flags. So we have to check for weakness and numbness, slur speech, any facial droop, severe headaches, vision changes, trouble walking, chest pain, syncope, any hearing loss, any neck stiffness. If any of those are present, then we have to think about something serious. Do you know what? Stroke, yeah. Stroke or any other neurological cause. So we have to refer them out for neurology or emergency department, wherever is suitable, right? For suspected BPPV, Dix-Hallpike maneuver confirmed the diagnosis, and the Eppley maneuver helped the crystal move back like where it belongs, right? You can watch the video on like Dix-Hallpike maneuver. It seems so easy to do it, but like my preceptor never had any training about like how to do it. We know like we just have to like move the head pretty fast, right? But we're not comfortable doing it. I haven't done it yet, so we just end up referring him out, and we did prescribe meclizine for him. Yeah, if any headaches or any red flags present, then we suggest him to go to the emergency department to get further evaluation. Yeah. Case was for right lower quadrant pain. So every time patients say like, okay, they have right lower quadrant pain, then appendicitis has to be considered, right? So I assessed her for any fever, any rebound tenderness, any gardening, any nausea, vomiting, and I did like abdominal examination. Her bowel sounds were like pretty active. She didn't have any tenderness or anything, but she did report like not having bowel movements for 2 days, and there was no sign of appendicitis and other abdominal emergency. Like her Robson signs and everything was negative. So her examination was reassuring, right? But like since she mentioned that she didn't have like a bowel movement for 2 days, I was like more lean towards the constipation, and my plan was like bowel clean out with Miralax and increase hydration and follow up like if any symptoms persist or worsen, right? So we did prescribe her Miralax for like a whole gallon of Miralax that we use for a colonoscopy thing. So we prescribed her that she has to finish that whole gallon of Miralax, and then we did encourage her to take Miralax for like at least for 2 weeks to keep everything running. And if anything, if her abdominal pain still persists and is getting worse or anything, then we did talk to her about all the abdominal emergency, like where she has to go to the emergency department, where she can like come to the clinic and all that. Yeah.